Hello, Assalamu alaikum. So welcome back to the topic approach to chronic liver disease in elder child. And yesterday we started this topic till differentials, that when there is CLD in an elder child, so what will be the differentials? There are four main differentials: the Wilson disease, the autoimmune hepatitis, the drug-induced hepatitis, and the viral hepatitis. Now, investigations. What are the investigations that will run in this case? In these cases, so there are three basic investigations. The first one is to how to screen for the liver disease and its nature. In the second step, we have to, once it is established that the child has a liver disease, we'll have to find out the severity. And the third one, we have to ascertain the etiology. So let's come to the first step, that is screening for the liver disease and the nature. So for that purpose, what we'll have to do, we'll have to test for the hepatocellular damage. We have to run the AST and the ALTs. Then we have to do the test for biliary excretion, the total and the direct bilirubin. Then they test for cholestasis like GGT, and test for liver synthetic function like albumin, PT, INR, and globulin levels. Okay, now in the first step, once it's established that it is a CLD, now we have to find out the severity, and for that purpose, we have to do the APGs first to find out any acidosis. We'll have to do the ammonia levels to find out the detoxification function of the liver disease, the albumin levels, and which will be serial, and that will show us marked hypoalbuminemia. Then the BSR, which will show hypoglycemia in CLD, bilirubin levels, which will be continued hyperbilirubinemia, electrolytes for any imbalance like hyponatremia, hyperkalemia, and prolonged PT-INR that is unresponsive to parental vitamin K. Now we have to ascertain the etiology. Once it is established it is a CLD, and once we have come to know that was the severity, now we have to do some steps, some investigations to ascertain the etiology. So the first one is Wilson disease. In order to rule in Wilson disease, basic investigations are four. Number first one, that is a serum ceruloplasmin level, which will be less than 20 mg per deciliter. The 24-hour urinary copper, D-penicillamine challenge, and the liver biopsy, which is gold standard. For autoimmune hepatitis, we'll do some tests, and which will show us high gamma globulin level. In type 1, we'll do asthma and ANA. In type 2, we'll do anti-LKM, anti-liver cytosolic antibodies, and in type 3, then we'll do anti-SLA. In drug induced, we'll go for the drug history, the drug levels. For infectious one, we'll be do screening for Hep B, Hep C, and CME serology. And for storage disorder, we'll do the liver biopsy. Now, in order to know what's the treatment, first of all, we have to make an outline that what are the basic things that need to be corrected in CLD. So let's start from the head. In head, we have to treat encephalopathy. In oral cavity, we'll have to deal with the nutrition. In esophagus, we'll deal with the variceal bleeds and the portal hypertension. Then in the blood, we have to deal with coagulopathy and sepsis. In abdomen, with the ascites. In skin, with the pruritus. We have to avoid drugs. In the ultimate treatment, that is the liver transplant. First of all, the most important thing, that is a multidisciplinary approach, which involves a pediatrician, gastroenterologist, ophthalmologist for endoscopy to find out any key offerings which are present in Wilson disease, a surgeon, a physical therapist, a dietitian, social worker, nurse, psychologist, and psychiatrist. First most important thing in the treatment, that is supportive treatment, which includes monitoring the weight of the child, the serum albumin, the PT, and psychosocial support, that is important. In step 2, we have to do in order to treat encephalopathy. Now the aim over here, that is to decrease the nitrogen load to the bowel, and then also the bacterial production of the ammonia. So for that purpose, first of all, we have to review that what are the precipitating factors, basically like some infection or some bleed or excess protein intake or some kind of electrolyte imbalance. And then we have to restrict the protein diet to 2 gram per kg per day, and substitution with branched chain amino acids will include leucine, isoleucine, and valine, and then oral lactulose, rifaximin, and neomycin. Now, for the cause of nutrition, for nutrition we have to be careful that that a child with CLD has high energy intake. He takes branched chain amino acids. He's on NG feed. We have provided with him fat soluble vitamins and zinc, iron, and calcium. Now, the fourth one, that is the portal hypertension and the viruses. For that purpose, intensive care management is important. We have to give the child IV fluids and the blood products, vitamin K, platelets, and FFPs. Then IV vasopressin, octreotide, band ligation, sclerotherapy, balloon tamponade, which includes the modified singstatin Blackmore tube, plus IV vasopressin and the intrahepatic portal systemic shunt. But this is very good tips, but it increases the risk for hepatic incap. Fifth one, for coagulopathy, we have to give the baby vitamin K, FFPs, and platelets. For sepsis, we have to start broad spectrum antibiotics. For ascites, we have to do we have to restrict sodium in the baby. We have to counsel them to restrict sodium intake, and that should be less than 2 mg per kg per day. Salt restriction should be 0.3 to 0.5 gram per day. We'll add spironolactone, furosemide, and abdominal tap. And in order to treat pruritus, we have to give the baby ursodeoxycholic acid. And the drugs to avoid the drugs to avoid are AGT, phenytoin, paracetamol, sulfonamides, and erythromycin. The most important step and the ultimate step, that is the liver transplantation, but there are some indications. The first one, that is the failure of hepatic synthetic function. You are running albumin levels but they're continuously low. Poor quality of life like pruritus, lethargy, anorexia, and infection. Intractable malnutrition, refractory ascending cholangitis, hyperammonemia, ammonemia, encephalopathy, esophageal varices from portal hypertension, hypersplenism, and some specific diseases like extrahepatic biliary atresia, acute hepatic necrosis, primary hepatic malignancy, etc. Now that what are the specific therapies, or what is a specific therapy? So in that you have to treat the cause, like for example, if it is due to BC, so you have to treat hep BC. If it is autoimmune hepatitis, you have to give prednisolone, azathioprine, and other immunosuppressant drugs. It includes replacement, for example, oral administration of primary bile acids, acylation and antioxidant mixtures, metabolic inhibitors, enzymes inducers, dietary restriction of galactose, galactosemia, and molecular manipulation, for example, inhibition of polymerization of alpha 1 antitrypsin and alpha 1 antitrypsin 1 deficiency. So, this was all about CLD, and I hope you learned and it made your concept clear. Thank you.